So our next presentation is by Judy Mathews. She has an extensive paediatric nursing background in clinical education and management positions. She's held the position of clinical nurse manager of the immunisation service at PCH for the last 3 years. This position within the immunisation service at PCH is the nursing lead for the Stan Perrin Immunisation Clinic. This service also oversees the nursing component of the Specialist Immunisation Clinic and the Western Australian Vaccine Safety Surveillance System at PCH in conjunction with the Department of Health. Thank you, Judy.
Thank you. Hi, thanks for asking me to speak today on the West Australian Vaccine Safety Surveillance, or affectionately known as WAVS. Some of it we would have just heard from Alan that I'll refer to, but I've been asked to just speak about the clinical pathway, which probably most of you do know because I'm sure that you all use it. Just to give you a little bit of history on WAVS, we were established in 2011 following the flu vaccine reactions causing febrile seizures in paediatrics. Originally, the reports went to the Department of Health and then to PMH. They got approximately 30 reports a month, and most of those were children having vaccines. Obviously, they were the biggest vaccine uptake people, and that's why it went to PMH. And in 2019, WAVS moved totally over to PCH. So the function of WAVS, we're a statewide comprehensive surveillance system that allows for close monitoring of adverse events following immunisation, or again, APHIS, including uncommon APHIS, safety signal detection, and causality assessment of severe APHIS or SAPHIS, and adverse events of special interest, which is ACEs. So if you like an acronym, this is the place to come to. So an APHI is any unwanted or unexpected event that follows immunisation. It doesn't necessarily confirm a causal relationship to a vaccine. APHIS that get reported to us are also include incorrect handling or administration of a vaccine. Most adverse events are mild, such as low-grade fever, pain or redness at the injection site, and these should be anticipated and don't have to be reported to WAVS. As Alan has already alluded to, we have two mechanisms to report to WAVS, and that is through passive and active reporting. And all reports are submitted via the online portal system of SafeVac, which is a 24-hour access online supporting system. So members of the public can report APHIS that they've experienced or their child or family have. And passive reports are received also from immunisation providers, healthcare providers, and reports directly from the TGA. And our active reporting methods include SmartVax and data linkage. So immunisation providers and medical practitioners in WA have a statutory requirement to report APHIS to the WA Department of Health through the WAVS system. SafeVac, I've just got the link there, which I'm sure that you've all used. And once you go onto that system, it's very clear of how to do it. You register if it's for the first time that you're using the system. You will, when you are registering, you'll have to give a contact number so that it's just a security code so that we know that the correct people are getting access to our system, and that will go to your nominated number, and then you will have access to the system. When you're putting in a report, the request is to give as much information at the time of reporting. So that just helps us with detecting straight away that there is an issue and that we'll be able to get it assessed as soon as possible. There's clinicians regarding we have clinicians that look at the reports as they come in, but we don't advise acute management, and we always suggest. I can remember on my very first couple of months when COVID started coming in with all our reports, and a lady rang at 8 o'clock in the morning, and it was, yes, how can I help? Oh, my husband had a vaccination yesterday. That's right. How is he? Oh, well, he's got chest pain. I said, where is he? She said, well, he's sitting here. He's having trouble breathing. I said, could you hang up and ring 000 because I can't help you? Oh, but it says that I should ring if I've got any issues. Anyway, it took about 3 minutes and she got off the phone. And as far as I know, everything went all right. But it was nerve-wracking for her. God, it wasn't good for me either. So our possible serious APHIS is defined as an event that results in death, is life-threatening, requires inpatient hospitalisation, results in persistent or significant disability, results in a congenital anomaly, or is deemed medically serious by our WABS clinicians. So the clinical workflow that you can see up there, the report comes in via SafeVac and is assessed by our nurses initially. And then if it is a common minor, the nurses will close it. If there's any other reactions or that they're concerned about some of the information they get, they will pass it on to the WAVS consultant. We had a WAVS consultant sitting with us during COVID all day, every day. As things have decreased, we have someone that we can go to, but obviously the events that are coming in are not half as bad as they used to be. So that WAVS consultant can either can speak to the patient or the person who has put in the report. They can request the medical records from wherever they had the vaccination or from the hospital, or can refer to the ECRG. And then depending on how that goes, it can be closed, can go to be referred to our specialist immunisation clinic either at PCH or Charlie's. And then following the report that we get from them is when the report is closed. So our WAVS team, as I said, is based at PCH. We do have one nurse now. We had 3 nurses sitting there during COVID. Now we have 1 nurse. We have very good admin support and there is, as I said, medical oversight from our on-site GP and our ID consultants. And the complex cases are discussed monthly in the ECRG meeting, and that's our expert clinical reference group. This is comprised of clinicians who have experience related to ACEs. When the referrals are sent off to the specialist immunisation clinic, those clinicians review and that is based on the causality of the World Health Organisation criteria, and then that correspondence is sent back to WAVS, that's where it's closed, audited, and data collection to see what the issue is. We collaborate with the TGA and FCAN on monthly meetings. And really from the 30 that we were getting initially to the over thousands, we're down to about 1,300 so far for this month. So there's a definite decrease. So that's it. So thank you.
Are there any questions for Judy?
Thanks, Judy. In the public health unit, we get often GPs reporting APHIS that are historical and the child hasn't maybe not had further vaccination. So we want the child to go to the specialist immunisation clinic, and we're not sure sometimes if the best pathway is a referral through CRS or a WAVS report that's historical.
It can be either. If there is a WAVS report, it's easier for us to refer straight on, but you can do it through CRS as well. Yes.
That's fine.
Thank you.